this is transformational. I think that really changed how we treat MSI high colon cancer. I'll be frank with you. In my clinic, just looking at the data in the refractory setting and seeing that about 1/3 of the patients will be cured with pembrolizumab, I've decided to move pembrolizumab in my clinic into the first line long before this data, as many of them don't even need to be exposed to chemotherapy in their lifetimes. And I'm glad I did that, because now comes KEYNOTE-177, which essentially took all these patients with MSI high tumors, and they randomized to either receiving pembrolizumab or chemotherapy of choice. This study had two co-primary endpoints: progression-free survival and overall survival. And we first heard a report about progression-free survival. Overall survival has not been reported yet and was not reported in this update. And that was under the request of the DSMB that they need to continue going. The reason why this data had a PFS co-primary endpoint is because you would expect a lot of these patients to cross over to pembrolizumab or other PD-1 inhibitors when they progress on the chemotherapy arm, and so they can blur the survival a little bit. Although one could argue that as you improve biology earlier on, you're more likely to see a survival benefit. So we'll see where that ends up. But the data was pretty striking. I mean, when you look at median progression-free survival, it was double with pembrolizumab versus chemotherapy. 16.5 versus 8.2 months. That's an 8+ month gain at the median of progression-free survival with a hazard ratio of 0.6. And that continued to be true with further follow-up. I mean, if you look at the 2 years mark, about half of the patients at the 2 years, half of the patients on pembrolizumab were still progression-free and alive at 2 years, versus about less than 20% with chemotherapy. It's quite remarkable. And then when you look at the durability of these responses, it's again more than 40% of these responses end up being quite durable with pembrolizumab. And the median duration of response has not been reached with pembro, whereby with chemotherapies, as you would expect it, it's about the PFS 10 months, interestingly. So with pembro, frankly, we think that more than 1/3, maybe even up to 40% of patients will be cured from their MSI high colorectal cancer. When looking at pembrolizumab versus chemotherapy, this was an update from ASCO GI, and they looked at PFS2. With PFS2, meaning looking at first and second progression, was not reached with pembrolizumab. With chemotherapy, was close to 2 years and maintained the hazard ratio. That actually gives me comfort that it is likely that there will be a survival benefit with pembrolizumab being given first rather than as an afterthought in later lines of therapy. Quality of life was better, of course, and toxicities are much better with pembrolizumab versus chemotherapy. So I think overall, the data continues to support undeniably, in my viewpoint, that pembrolizumab should be the standard of care for first-line therapy in patients with MSI high metastatic colorectal cancer. Attempts to try to intensify the immune therapy piece with adding a CTLA-4 inhibitor to PD-1. We've seen some data with ipilimumab and nivolumab, which looks interesting. But in the absence of randomization, at this point of time, one would question the added cost and added toxicity of the combo versus single agent PD-1 with the results we're seeing with KEYNOTE-177. So I would not support the use of dual PD-1/CTLA-4, so dual checkpoint inhibitor, and I would certainly consider pembrolizumab single agent as the only standard right now outside of a clinical trial.